Alicia Gallegos reporting for Frontline Medical News. Today we're speaking with OIG Chief Medical Officer Dr. Julie Tatesman about how doctors can avoid Medicare fraud. Thanks, doctor, so much for joining us today. I'll go ahead and just dive right in. My first question is, what are some common ways that physicians come under Medicare fraud suspicion?
Sure, and first of all, thank you so much for giving us the opportunity to reach your audience. Educating physicians to become our partners in preventing Medicare and Medicaid fraud, waste, and abuse is an important part of the Office of Inspector General mission. So I'm delighted to have this opportunity to tell you about common ways that physicians get in trouble for the purpose of getting that message out to your audience, your readership, so that they don't fall prey to those scenarios and they stay out of trouble on the front end. So there are numerous ways that physicians can come to the attention of this office and be subjected to enforcement actions. One of the most common ways is someone reports them. We maintain a hotline, 1-800-HHS-TIPS, that providers, patients, members of the public can call in or email in and report suspicions about a physician or other provider. So that's one way that a provider will come to our attention, and then we have a group of investigators, they're special agents, trained law enforcement investigators who would take that tip and then, if there's merit to it, investigate the particular provider. Another way that providers come to our attention is through our data mining efforts. We have access to Medicare and Medicaid claims data, and we have a group of analysts who review that data for aberrant billing patterns, aberrant claims patterns. Now, an aberrant pattern doesn't necessarily mean fraud, doesn't necessarily mean that there's a problem, but it raises a flag. And if we see an aberrant pattern, that in and of itself doesn't mean the physician is doing anything wrong, but it might mean that we need boots on the ground to look at that physician's practices and see if that represents legitimate billing or if that represents problematic behavior. And then the third way is our largest component is actually auditors. As an office, we're probably most well known for our law enforcement activities, but our biggest group is actually auditors. And some audits are targeted and some audits are random, and a provider might be selected either targeted or randomly for an audit, and our auditors review their claims and can identify problematic billing behavior.
Absolutely. And also, doctor, do we know in general about what portion of Medicare fraud is committed by physicians?
We don't, and getting at the actual amount of Medicare fraud in general or Medicare fraud by physicians is incredibly difficult. We can tell you about the fraud that we've identified, but we don't know what the total body of fraud is. And I have a couple examples of physicians who have recently been charged with healthcare fraud that I can share with you. But what I first want to start by saying is why it's so important for physicians to practice with integrity, and we do believe that the vast majority of physicians do practice with integrity, is because physicians control the bulk of care, healthcare items and services that patients receive. So even though physicians don't receive the lion's share of Medicare payment, they control, either by ordering or prescribing, the lion's share of Medicare items and services that Medicare pays for, which is why it's so important for physicians to be our partners in promoting high quality care, promoting efficiency and compliance with the rules. One number that I would like to toss out is the number of excluded physicians. Now, there are currently about 5,000 excluded physicians, and what exclusion means is that a provider is basically kicked out of the Medicare and Medicaid programs for a period of time, maybe 3 years, maybe 5 years. The government determines that the provider is either such low quality or so untrustworthy that they won't be allowed to bill Medicare or Medicaid, which means they can't treat Medicare and Medicaid patients. In the healthcare law community, it's often referred to as the capital punishment of healthcare law because it makes it incredibly difficult for a physician to make a living practicing medicine as an excluded provider. Now, 5,000 isn't that huge a number in terms of the total pool of physicians, but really that number should be should be zero. I mean, you would hope that no physician gets excluded. The commitment to become a physician is so high, the number of years of training. We see some providers go into durable medical equipment supplying, specifically for the purpose of cheating Medicare and Medicaid. Disreputable organizations will start up a fly-by-night DME company in a strip mall, often in South Florida, and bill millions of dollars to the program without providing services. I don't believe that there's a single college junior, college senior in the United States that decides, I'm going to sit for the MCATs, I'm going to go to 4 years of medical school, I'm going to go to 3 years plus of residency training for the purpose of cheating Medicare. We think that there are physicians who act fraudulently, but that couldn't possibly have been their plan, 10-year long-term plan to become a doctor and cheat the Medicare program. But we think that there are various reasons, some accidentally and some purposeful, where they end up in situations where they're fraudulently billing the program. So we have about 5,000 excluded providers, and then I can tell you some numbers on fines from enforcement actions against physicians.
Okay, well, maybe you can give me an example, one recent example of a doctor who has been in trouble.
Some things that we've been recently seeing are fraudulent medical director arrangements. Now, as your audience I'm sure knows, there are many situations where it's perfectly legitimate for a physician to serve as a medical director for a nursing home or another provider, and that physician offers real services, provides however many hours on a daily or weekly basis, ensuring that the quality of care at that facility is appropriate, overseeing clinical standards, providing other legitimate real value services to the facility. And there might be one medical director, there might be two, there might be a small number of medical directors, but no more than the facility actually needs for the medical director service. What we're seeing from some providers is these fraudulent medical director arrangements where the provider uses a medical director contract as a cover for paying a kickback to the physician, and so names often several physicians as medical directors as an excuse to pay them, not for providing medical director services, not for ensuring the quality of care at the facility, but as a cover to pay them for their referrals, to pay them for sending their patients to that facility. And where we've been seeing it a lot lately in recent days is with imaging centers, imaging facilities paying multiple medical directors.
Okay, interesting. And actually, kickbacks was one of the things I wanted to ask you about, so why don't we just talk about that next? What type of role does kickbacks play, and how do doctors, I guess, get into kickbacks, and what should they avoid?
Sure. Now, kickbacks, there's a rule called the anti-kickback statute, which makes it illegal to pay a physician or any other person money or anything else of value in exchange for sending their patients for Medicare, Medicaid, federal health care program payable services. Now, sometimes the kickback offer is very clear-cut. An imaging center will say, I will pay you $50 for every patient that you send to my facility. Sometimes, and physicians should recognize that that's problematic. Some kickback offers can be a little bit harder to identify. Perhaps instead of offering the $50 per capita payment, maybe they offer, I'd like to make you my medical director, and here's your reimbursement package. And it seems a little bit too good to be true because it's offering a lot of compensation for and not a lot of work. Sometimes the kickback might be not actually giving money, but giving a discount on something. We might see a hospital offering physicians to rent office space at the facility, and the rent might be much lower than market value. And the reason is the hospital knows that if the hospital lets the physician have a below market value office rental at the site, they'll get more hospital patients from that. And there are situations where the physician might not at first blush recognize that the offer is a kickback, which is why we ask that when someone offers you an investment opportunity, an office rental, a consulting agreement, to look behind it. Now, sometimes it really is obvious. We had a case last year where the physician was being offered kickbacks to write fraudulent prescriptions, and the kickback can be anything of value. This kickback came in the form of cocaine. So in that situation, we think the physician had to know that something was not quite legitimate. But there are other scenarios where well-meaning physicians can stumble across a kickback arrangement because they don't realize that they should be looking behind the offer, some too good to be true investment opportunities.
Mm-hmm. Okay, definitely something for them to keep in mind. Now let's talk about the False Claims Act. I want to know, how important is this law to doctors, and how much awareness do you think is out there of how this law applies to physician practices?
I think the False Claims Act is incredibly important to doctors. The law protects the Medicare and Medicaid programs, the federal health care programs, and it protects our beneficiaries, both by ensuring that our beneficiaries get good services and then that our programs pay the proper amounts. It's a very interesting question in terms of how aware physicians are. We did a study a couple years ago looking at how much medical schools and residency programs teach about fraud, waste, and abuse. We interviewed deans and residency program officials, and what we found is that the schools don't teach all that much. So physicians aren't learning very much about it in their formal training, but we hope that when they get out into practice, they're learning about this law. And it's a very old law. What's interesting about this law historically, the False Claims Act came out of the Civil War. It's an old statute, and it was passed. People were selling lame mules to the Union Army and billing the Army as healthy mules. And so there was the twofold problem. First, it was endangering our soldiers, that they're relying on shoddy animals for transportation when they need healthy animals, and then the taxpayers are paying too much. And that's the same application now. It's when providers are either providing bad items or services, it harms our beneficiaries, or when they're charging us more for those items and services than they should, it harms both the beneficiaries who have a copay obligation and the taxpayer who underwrites the rest of the payment for that.
Absolutely. What are some top strategies for physicians? We've talked about a lot of ways that they might come under scrutiny. What are some top ways that they can avoid Medicare fraud?
We think compliance plans are incredibly helpful. Now, for years, the Office of Inspector General has been advocating for providers to voluntarily adopt compliance programs, and we have guidance that we've made available for free on our website offering instructions on how to develop a compliance plan. The Affordable Care Act, as part of that healthcare reform legislation, will require all providers to have in place effective compliance plans, but the guidance on that will be developed by CMS, and CMS has not yet written that guidance, so that will come sometime in the future, the guidance on how to establish a compliance plan that meets the mandatory requirement. But in the meantime, the Office of Inspector General offers some very helpful guidance on how to develop a compliance plan that will help avoid fraud, waste, and abuse.
Okay. And speaking of compliance programs, what resources do you need to have to develop such a program, and what about for smaller practices?
Yeah, I'm glad you asked that, because there is no one-size-fits-all compliance plan, and we offer general suggestions on what your compliance plan should do, but how that compliance plan will look will really depend on the size and nature of your practice. We always recommend that a compliance plan have a designated compliance officer. Now, for a big hospital, that means a vice president of compliance and a full-time staff of several people, and they usually set up an anonymous hotline and ways to report in a two-person medical office. No one expects that you can have a full-time compliance officer. Your compliance officer might be a physician, a nurse, a receptionist, someone who is the designated compliance officer, but that's not 100% of their time. They also have other clinical or administrative responsibilities. So we believe that no practice is too small to set up a compliance plan, but the compliance plan should be designed to fit that practice, and if appropriately designed, we understand that there's always some administrative burden to establishing a compliance plan, but if it's done right, the benefit will always outweigh that burden.
Absolutely. Lastly, what do you think the future holds for Medicaid fraud and physician compliance, and anything you'd like to add about OIG efforts, ongoing efforts?
Sure. We are probably best known for our enforcement actions. We're really good at enforcement. That's what you see in the news stories about OIG, but we are really making an effort to promote compliance. As good as we are about enforcement, we would much rather there be no violation in the first place. So we are undertaking extensive efforts to reach out to providers and explain these specialized fraud and abuse laws ahead of time, and we're really making efforts to reach providers in new ways, like your publication, like your journals, to try and get the word out to providers ahead of time and help them comply with the laws, treat patients with the proper quality of care, and build the programs using appropriate procedures so that we can avoid the need for enforcement actions. And we think, certainly providers are happier not to have enforcement actions, and from our perspective, we'd rather have compliance than enforcement as well.
Thank you, doctor, so much for joining us today. For Frontline Medical News, I'm Alicia Gallegos.